I'm Dr. Dahiya, originally born in India. My medical degree undergraduate is from India. All of my residencies and fellowships are in this country. I sort of have gone a rather lengthy route. I did the fellowship first in that I'm going to be a cancer surgeon, so I did 2 years of surgical oncology. And here came all of a sudden that, hey, we can do the surgery through tiny little cuts and holes. And so at that time, there were no fellowships. So I'm from the batch, what we call the first year. We all each other taught, hey, I learned this and I learned that. So I did a lot of teaching in laparoscopic surgery for the gallbladder, as well as even then migrated to the bariatric surgery, even that. Not only in the US, but I also, for about 3 years, I used to go every 3 months to Bangkok. I used to teach and do surgery over there. And I've even had, as far as Australian surgeon came, and even over here, like for example, the USC doctors came and I taught them to do the bypass laparoscopically. I'm not from the open surgery days. I am from the laparoscopic days. Since I self-trained, so I don't have the fellowships, so on and so forth, but I have not only taught, but we used to have fellowship where somebody came for 2 years and we used to teach him. So that sort of, that led me to bariatric surgery. Tri-City has been in the business of bariatric from the early, the days of the inception, when we used to have so complicated cases and everything was open, and there were not that many the lower risk patient, because it was kind of like a taboo. So when somebody has been in the business that long, they develop their infrastructure. And infrastructure is what you need. And they have that. There are choices, and then there are also different patients. Not all patients can be done in a surgery center. There are some, what we call the very low risk patient, and mostly lap band patients can be done at a surgery center. Gastric bypass, at least right now, the community standard is that we need 2 nights of stay. They also are a little more complicated. What if they need a cardiologist, they need a pulmonary doctor, or any other specialty that we can't all of a sudden provide in a surgery center? Therefore, the bypass pretty much becomes inpatient at the present time. Just because of the needs of all of these different specialties that we can't provide in an outpatient setting. There are lots of them, actually. One is a grandfather. Could never play with the grandson. The grandson used to tease him, oh, grandpa, haha, you can't teach me, catch me, and all of a sudden, 6 months, 8 months down the line, he's lost quite a bit of weight, and all of a sudden he catches the grandson, he says, haha, finally I got you. And he was so proud, he came and told me. Then there are patients who, I just recently did, gentleman is either from Argentina or Colombia, Southern American gentleman, takes insulin, glucophage, and like 10 other pills. We do a bypass and comes back, usually about 7th, 8th day, we take the staple stitches out, and he says, doctor, I'm so grateful. I don't need insulin, I don't need glucophage, I am absolutely great. And these are the things, there are lots of others. And that's what keeps us in this complicated surgery. You always want to see that, are you helping somebody? It's sort of, it's a very fulfilling thing. A surgeon actually is blessed in the fact that, we can see our results almost not instantaneously, but almost immediately. And you know that sense of fulfilling that, hey, you know, I'm doing some job, something worthwhile. Comorbidity in the strictest term is that if you were not overweight, you wouldn't have that disease. And three are the most recognized one: diabetes, type 2, blood pressure, hypertension, sleep apnea. But then if you look at the other things, those are comorbidities also. We know that, for example, breast cancer is higher in obese women. All the joint diseases, whether it's the back or knees or ankles, those are there. The depression, and lots of other things. Just the stigma of living in this society psychologically, that everybody kind of gives you those slanted looks. So in a way, all of these are comorbidities. And it gives a relief to all of them. A good procedure will take care of most of those. There are simplest way to explain is that how many kilograms are you carrying for a given height, and it's measured in meters. But if you were to be exact, if we were to square your height in meters and take the weight in kilograms and divide with the weight divided by the height, it gives you a number. And then again, as I go back to it, that in simplest term, per unit of your height, how much weight are you carrying? And that's the body mass index. This is a procedure that, in the strictest term, it's a very elective procedure. It's not like appendicitis that tomorrow, if you don't do it today, your life is in danger. Therefore, elective procedure, at least I feel obligated to mention at least the serious complications. They need to know going in upfront, even if it's a less than 1% chance. And by the way, these days we've done so many of these that we've gotten good at that the complications really are not as they used to be. I've done probably 1,500 cases. I can tell you that complication rate is probably 1 to 1.5%. But going back to it, they need to know. I don't want somebody blindfolded, taken, and have a procedure, and then, oh, by the way, you got this. The bariatric surgery for me, I started in year 2000. I have done close to 1,500 cases, except for maybe total of 6 or so in all these years. All of them have been laparoscopic. Complication and experience, they go hand in hand. Earlier on, most of us surgeons who started laparoscopically, there was a slightly higher chance of having complications, so that's where the experience comes in. In laparoscopy, you're basically working like a Nintendo. You are in a two-dimensional vision. You're not in three-dimensional vision, so it takes, if nothing else, for you to be so dexterous and realize that this is 2D, and how can you tell that something is 6 inches close to you and the other thing is about 8 inches farther than you. And experience has shown that it does matter. Our complication rates are gone. My average stay of a patient in the hospital is less than 2 days. So all of those things point, yes, you should look for experience. As far as lap band, I know that it's touted as that, that's the least complicated procedure, and a term minimally invasive is being thrown. And I think that some of it is the confusing issue for a layperson. Minimally invasive, they don't know. Right now, bypass and band are both minimally invasive. They're both done laparoscopically. So the only difference becomes, do we cut little intestine here and there, or we don't. And over the years, we were trained even from the days of residency, we cut and sew the bowel. So it's not that much difference. Personally, in my practice, I do band, bypass. I haven't seen that much difference in the complication. And that may go contrary to what's being, on the television, the ads, the commercials, and all that. But again, I'm going on my experience. There's not that much difference in the complication. The heart, for example, is the center of, blood has to go everywhere. And if you were to have a compromised heart, of course, yours is going to be a different risk than somebody with a good heart. The same thing will apply to all other things. And that's why the workup for these conditions is very thorough. We check psychologically the heart, you may ordinarily just get by with a EKG. Here we do the echoes, the stress test, and all of that, because we know that weight in itself is a high risk. So when you add diabetes, blood pressure, the heart, and so forth, all of this become additive, and you have to do the workup to get the person in the best shape that they are going to be, so that the least possible complication chances that you can provide that person. The whole concept is that we are reducing your weight. And hopefully, if you do everything right, then majority of it will be the fat content in the body. You will do your exercise and all that, preserve the muscle. But on the other hand, this is different than liposuction or anything like it. What we are doing is we are taking the cause that weight gain occurred from and address that, as opposed to liposuction is, well, we'll take this little fat out now, but it'll keep depositing for tomorrow. So in that sense, it's different than that, and we are also not doing for cosmetic reasons, we are doing for health reasons. So answer is absolutely yes. I want you to have a better health, I want you to have a better weight for your body, and that's what we need to do. Old rule of thumb, if you are 100 pounds more than your expected weight, and the expected weight comes from the life insurance tables years ago, then go look into it. We have gotten to be more sophisticated. Being that there's no absolutely perfect formula, but body mass index, which tells for what height, how much weight, is the absolute way to find out. But if you are give and take 90 to 100 pounds is over, look into it. Find somebody, and that's somebody by, I mean a doctor who has an experience. Go talk to his patients, look into if he has had good outcomes. That's sort of the first point. After that, the doctor is going to take you through, check the heart. We're required to check psychological for issues. What if you have some eating disorder or something like that? So, and sometimes we even check the endocrine part, because there are certain endocrine disorders also that totally take the control out of your hands and you gain weight. And all of these will be worked out by your doctor after that, once you find somebody who has a program that is in itself has a coordinator and so forth. They're going to handhold and carry you through.